welcome again. Good afternoon, and welcome in this symposium dedicated to the rationale and clinical application of endotoxin removal therapy. The symposium is supported by the Estor Direx. It's a great pleasure for me to introduce Richard again, very expert on that, and we will discuss on some pathophysiology and possibility to be more precise in the use of blood purification, as Thomas mentioned before. Thanks a lot, Richard.
Thanks, Massimo. So in this session, we have three presentations, so I'm going to open with a little bit the rationale why it makes sense to consider endotoxin as a therapeutic target. So we discussed a lot this morning about the process of care, and we try to provide the best care to patients with sepsis. But still, because after providing the best care, there are some patients that in fact they are not responding and they have a severe condition not responding to this initial therapy. And the reason for that is this dysregulated host response. So the patients that do not respond are those that have this immune dysregulation compared to those patients that have an adaptive immunological response and they recover in the early phases of the septic process. So we should focus in that, and that's why we are talking the whole day about immunomodulators. The ideal immunomodulator should be one that is able to reduce the inflammation, to control the inflammation, but at the same time to preserve the immune function and to control the infection. But we know that there is a lot of heterogeneity here, and this is translated in heterogeneity of treatment effects, and this is the main challenge we have in sepsis. So we talk about different subendotypes and different subphenotypes that may respond different to therapy. And also we discuss that this is a dynamic process, and a patient one day can be in an hyperinflammatory phase and the next day can be in a hypoinflammatory phase. So it's something that we need to monitor, and Massimo Girardis gave an excellent talk on that. We talk also about that we need to find treatable traits for patients with sepsis. So this is the way to reducing the heterogeneity and go for a subgroup of patients that are quite homogeneous and they have a specific target. So this is regarding the infection and the patient. And regarding the therapies, we have some therapies that are called extracorporeal blood purification techniques that in fact have several indications. So there are some immunological conditions that are treated with several of these extracorporeal blood purification techniques, also liver failure, some intoxications, and some other syndromes. They are treated with this type of techniques. But also, what we are discussing today is the group of patients with sepsis. You also, Thomas, have shown you the list of devices that are available. Those are those who are non-selective systems for removal of different mediators of the inflammatory response. And there are others that are working in more a selective way, and Polymyxin is one of them. It's selective for removing endotoxin. And also Thomas mentioned about Sara, that is selective for removing pathogens, despite it's not very selective because it's able to remove a huge list of different bacteria, fungi, and virus from the blood. So if we consider the classification in a different way, we are talking about those absorption therapies, specifically now those absorption therapies that are selective for endotoxin. So those devices have different properties, so have the capacity of absorb different substances. Regarding endotoxin, I mentioned that Polymyxin has the capacity to absorb selectively endotoxin, and is the device that have the higher ability to absorb, to remove from the circulation this specific PAM coming from gram-negative infections. Oxiris is in the intermediate, and Cytosorb have little capacity to remove endotoxin. On the other side of the slide, we have seen for cytokines that Cytosorb is the one who has higher capacity to absorb cytokines, and of course Polymyxin is designed for endotoxin, is selective, so it's not removing cytokines at all. So at the end, when we are talking about precision medicine, we have to match this specific subphenotype of patients with the machine with the adequate therapy. So we have to do this matching. So we have to select the right patients for the right therapy. And you have seen that it's a huge list. So in fact, I think if you are thinking that you want to do blood purification, you need several devices because each of them have different approaches. So we need to match these two strategies. So enrichment, you have seen that. And enrichment, in this case, it's let's go for patients with endotoxic shock. Endotoxic shock means that the concentration or the activity of endotoxin in the blood is high, and this endotoxin is coming from gram-negative infection and also for gastrointestinal translocation. So after the lysis, you know that endotoxin is a component of the cell wall of gram-negative bacteria. So when there is a lysis by antibiotics, there is a liberation, huge liberation of endotoxin, but also there is endotoxin coming from the gut. So we have 25 grams of endotoxin in our guts, and when there is a disruption in the gut barrier or when there is that gut dysbiosis, there's the possibility that this endotoxin translocate from the gut to the circulation. We show that in this study done in 12 COVID patients. So there are COVID patients, viral infections. There is not gram-negative infection in that situation. And you can see here that those 12 patients have a nice correlation between severity, SOFA score, and the activity of endotoxin, suggesting that those patients who have higher severity have more translocation for the gut, and despite they don't have a gram-negative infection, they have this subphenotype of endotoxic shock. So the correlation between endotoxin activity and severity is well established. In this case by John Marshall, but it's very well known since several years ago. So this is the subphenotype we are describing. It can go with multi-organ failure, and the characteristic, of course, is that the levels of endotoxin is high. It's very well known that PAMs, endotoxin is one of the PAM, is one of the trigger of the inflammatory cascade, activation of the endothelium, activation of the coagulation, alteration in the microcirculation and organ dysfunction. This is well known, but it's not also well known that some of these PAMs and endotoxin is able to produce direct organ damage. So that is part of the rationale why we are treating those patients with this subphenotype. So you know that endothelium is one of the targets. It's one of the main, let's say, organs that are affected during sepsis, and endotoxin alone, injection of endotoxin in these mice produce endothelial damage. And this endothelial damage and alteration in the microcirculation can be blockade if you are able to blockade toll-like receptor 4. So there is a direct effect of endotoxin in the microcirculation. Jean-Louis talked about myocardial dysfunction. He explained us this can be systolic, can be diastolic, can be both, can be reversible. It's interesting. It's induced many cases just for the circulating cytokines. So in isolated cardiomyocyte, it can be induced by the circulating cytokines, but also by LPS by itself. And in fact, the cardiomyocytes have toll-like receptors also in the membrane. So there is a direct interaction between the microorganisms, the PAM, and the cardiomyocyte that can induce this also septic myocardiopathy. So and again, some rationale for removing endotoxin from the circulation. You have seen also this slide about sepsis-associated AKI is getting more and more important, and this is an organ that we are focused now trying to prevent further AKI with different bundles, but also with potential drugs. One of the potential drugs is alkaline phosphatase, because alkaline phosphatase is able to dephosphorylate endotoxin, and it's preventing that the endotoxin is able to produce systemic inflammation, but also local effects in the kidney. This hypothesis was tested in this trial, where patients were randomized to alkaline phosphatase or placebo. The main primary outcome was not achieved, which is improvement in renal function during the first week, but it was achieved a secondary outcome, which is improvement in kidney function after the first week. So it seems that is able, acting in the endotoxin pathway, to prevent AKI with this drug. This is still unpublished, but it's submitted to intensive care medicine. So this is Revival, which is the study that was done after the previous one. There is not effect in all-cause mortality, but again, there is a prevention in a major adverse kidney event using alkaline phosphatase. So could be part of the explanation. And when you go to the pathophysiology of AKI in sepsis, you can see that the pumps and dams and also endotoxin is able to cross to the tubular lumen, and in the tubular lumen, again, the tubular cells have toll-like receptors able to sense endotoxin and to produce damage in these cells with a constriction of the afferent arteriole, and this goes with a decrease in the glomerular filtration rate and explains AKI in these patients. And the same for RDS. So the administration of LPS produced diffuse alveolar damage very similar to other experimental models of sepsis. So at the end, we have endotoxinemia producing systemic inflammation and organ damage, but you have seen that endotoxinemia is also able to damage organ by organ directly. So it could make sense that removal of this endotoxin using this device can be useful for patients. You know, the main results of the EUPHRASIS trial was negative. There is this subgroup analysis in patients with intermediate levels of endotoxin activity. So this is EUPHRASIS trial was an enriched trial. Trial was enriched for patients that have septic shock, multi-organ failure, and endotoxin activity above 0.6. In this case, in the post-hoc analysis, there were removed from the analysis those patients that have endotoxin activity above 0.89. So this is being tested in another prospective trial called Direx in North America. So let's see if this trial is positive. Meanwhile, I'm showing some recent results about this therapy. This is coming from the patients I told you that we studied during the COVID outbreak, and those patients that have COVID-19 with high levels of endotoxin, we treated with this device. So we did blood purification with PMXV, and we show a reduction, an improvement in SOFA score, lactates, mean arterial pressure, and vasopressors during the therapy. Despite we select the patients based in endotoxin activity, so despite we try to enrich the samples, there are some patients that improve very fast in terms of endotoxin activity. So we consider responders in terms of biomarker measurement, and some of the others that are, in fact, I don't think we can call it no responders. It's late responders that the levels of endotoxin it takes more time to decrease. But this is the kinetics you can expect in those patients. This has not been very well studied until now. And here you have some data in what you may expect regarding the levels of endotoxin, what type of reduction of endotoxin you may expect, especially in those patients, to respond to this therapy. Timing is very important, but also selecting the right group of patients. We also analyze the Japanese registry database. You know that this is a standard of care in Japan, is completely reimbursed, and many patients are treated with this type of devices. So analyzing the registry, you can see here in this analysis that the patients who have SOFA score between 7 and 12 are the ones that respond compared to a control group. And regarding timing, also, especially for those patients with abdominal sepsis, also in that study, the cutoff, I think, is 9 hours of vasopressors. Those patients with abdominal sepsis, that are those we expect that they have the higher burden of endotoxin, are those that if you treat it in the early phase, they respond better in terms of survival compared with the patients that are treated later. For extra-abdominal sepsis, this is not so clear that this 9-hour cutoff could be used for treating patients. But I'm sure that Massimo will deliver more about that. So the conclusion is that maybe we can consider endotoxic shock as a subphenotype of patients with sepsis. It's a subphenotype that have a treatable trait. You can measure levels of endotoxin, and you can decide that you want to remove endotoxin in those patients. Of course, especially in those patients that are not responding to initial therapy. And this is, again, a type of diagnostic approach of precision medicine in this setting. Thank you very much for your attention.
I'll move there, Rick. Thanks a lot, Ricard. I introduce myself. I'm there because I'm on the same line of Ricard. And with my presentation is the aim of this, I hope, 10 minutes, is to continue discussing about how can today apply the knowledge that we have concerning the endotoxic shock and the method for clearance of endotoxin in the blood in our daily life, clinical life, of course. My disclosure, and the tentative is to overcome this problem that is quite clear. All the adjunctive therapy in the surviving sepsis guideline, but it's the same in the Cochrane database, became red faces in the last years. And so we wrong something in the research. Probably now we are in the last year, we improve our methods for randomize our patient to include the patient in the trial, but up to date, all the faces are red, but the patients still die for septic shock. And I think that this is the reason why, the blood purification by Polymyxin-B HemoPerfusion was indicated against in the surviving sepsis campaign. The results are just one big trial, well-designed, phase 3, that was at the end negative in terms of survival rate of the patient. But as we discussed since this morning, we have all the same approach. All the patients are similar is not the correct approach. The one-size-fits-all is not the correct approach. So we have to phenotype the patient, immunotype, treatable traits, and so on. Probably endotoxemia and polymyxin-B is a treatable trait at the end of the story, because it's not only a matter of sepsis. It could be a matter also of trauma, could be a matter also of burn, could be a matter also of other disease, not only related to sepsis. What about the subgroup phenotyping? You know that before the publication of the secondary analysis of the trial from the US, of the Euphrates trial, we had some indication from this meta-analysis, including also the study of the Euphrates, indicating that the clearance of toxin, of endotoxin by polymyxin-B seems to be more effective in patients with less degree of sepsis or septic shock. The same for is sepsis, the same is for the Apache score. And particularly important in all this trial, in the majority of this trial, the effect was not only in the mortality, but is also in the decreasing the cardiovascular failure, decreasing the SOFA score of the cardiovascular system. So again, before the publication of the sub-analysis, we have indication that probably the patient with very high endotoxic shock, hyperinflammatory shock, overwhelming hyperinflammatory shock due to endotoxin level could have some benefit. And this is, as Ricard pointed out before, the results of the sub-analysis of the Euphrates trial. Patient with endotoxin between 0.6 and 0.9, including only this population, the effect of polymyxin-B was impressive in comparison with control. The difference in mortality was 11%. Not only mortality, but also some better increase in mean arterial pressure, decreases in vasopressor index, more free days from ventilation, from RRT, a lot of clinical significant effect if we select the appropriate population, as indicated in the meta-analysis, as indicated from this secondary analysis of the Euphrates trial. What are the reasons? I think at the end of the story that the reason is that probably we've wronged the dose of the therapy. You know that during the Euphrates trial, the indication is for 1 or 2 treatments with the polymyxin-B HemoPerfusion. But if you calculate, I think it's an interesting analysis. But if you calculate the quantity of endotoxin in the interstitial space of patients with an endotoxin activity between 0.6, 0.8, or 0.9, you have around between 10 and 50 micrograms to remove from the body. But if you go further with an endotoxic activity higher than 0.9, you have more than 52 micrograms. And we know, as Rika showed before, that the capability of polymyxin-B absorption capacity is around 64. So if I have a patient with a lot of endotoxin in the blood and interstitial space, maybe that the dose is wrong. And this is why probably in many patients we have this effect. We have a threshold. This is a clinical effect of hemoperfusion. Good effect, negative, no effect. Yes, some positive effect. Of course, if the concentration of endotoxins is below 64, probably we have an effect, positive. If the concentration increases, we have no effect at all, as antibiotics, as probably the steroids. And I think that in the future, the appropriate dose and the measurement of endotoxin during the treatment will lead to change the approach in the trial. 1, 2, 3, maybe only one treatment is better than 2. 3 is better than 2. It depends, of course, on the evolution of the patient. You can imagine a patient without any control, SUS control of in abdominal surgery, the quantity of endotoxin produced by bacterial lysis is a huge amount, so you can't control just with 1 or 2 treatments. Moving from mortality to organ support, we know, as I mentioned before, we know for sure that in all the trials, this is a very famous trial published in 2009, with also Massimo there in the study, for sure in all the trials we have an increase in cardiovascular reactivity, means a decrease on noradrenaline or other vasopressor support and an improvement in esophageal cardiovascular system. But what is most interesting for me, this is again a study published from the group of Massimo, just published some days ago, and it's the fact of polymyxin-B on the reversal of septic cardiomyopathy that presented before Jean-Louis. And they try to understand first if endotoxic septic associated cardiomyopathy is related to endotoxin and if the clearance of endotoxin from the blood could revert this cardiomyopathy. And there's no clear relationship between endotoxin activity and the possibility to express septic cardiomyopathy. The endotoxin activity in the group with and without cardiomyopathy was quite similar, just a little bit higher in patients with cardiomyopathy. But it's interesting that when you remove endotoxin activity, you have a better improvement. This is the probability of to have reverse of septic cardiomyopathy in time, and patients receiving polymyxin-B show an improvement at the end of the ICU stay. A higher percentage of patients reverse cardiomyopathy, and not only at the end, but also during the stay in the ICU. This is another idea, because when I have a patient, the mortality is my endpoint and the end of the story, but during the days, I want to support some organ. Cardiovascular means arterial tone and mean cardiac activity. The same is for microcirculation. I showed before by Richard. There is a clear impact of endotoxin on the microcirculation, and the possibility to decrease the impact of endotoxin on the microcirculation is important, as shown in this study by the use of OPS for understanding the effect of polymyxin-B hemoperfusion on the microcirculation in terms of perfusion of the microcirculatory organs, of the microcirculation of the organ. Immune effects. Again, from this morning, we talked that immune system is an organ. Not really. It's not correct, but it's important in our approach. And we know for sure that in many patients, there is a decrease of, unfortunately, mediator on chemokines. And I fully agree with Thierry before, say that we don't know exactly what does it mean, but we know that when we use polymyxin, we decrease all the cytokines. And probably this could be the point why in some patients there are elements indicating that the Polymyxin-B HemoPerfusion works, and in other it doesn't work. Again, but we know that something on the endotoxin, on the cytokine and the chemokine happen during the treatment. The same is for cellular response to sepsis. You know, HLA-IDR, as I mentioned this morning, is related to the innate immunity, and the higher is HLA-IDR, the better is the immune system. Again, by using polymyxin-B in patients with high endotoxin level, and the clearance of endotoxin improve the HLA-IDR response of this patient. So not only for mortality, but for supporting vascular tone, cardiac, microcirculation, kidney, as mentioned before by Ricard, and the immune system. I want to conclude with some indication. This is one protocol to put in real life this method. This comes from the group of Ricard, and look into the septic shock patient. Of course, refractory septic shock, the definition, of course, should be better studied, evaluated, or defined in the future. If you have a very high endotoxin level, you can consider in a patient with very refractory shock the use of endotoxin clearance method, polymyxin-B HemoPerfusion. If the two are combined, the group of Ricard proposed to consider some HemoAdsorption for cytokine and selective absorption. As I fully agree that the difference is that with one system we are very selective, very precise, we block endotoxin. With the other methods, we probably are just imprecise, as I mentioned this morning with the immunoglobulin, but could be that in a specific immunophenotype of the patient we could get some advantage. This is the same story proposed recently in the sequential therapy to put in our protocols blood purification. It could be, the rationale is that if you have a patient with an endotoxic shock, all the values, classical values from the endotoxic shock, and you could measure also the endotoxin level, probably it's time after source control antibiotic therapy to use something of very precise as polymyxin-B. If the situation doesn't improve and you stay in a sort of refractory shock, and you have also the possibility to measure something more, indicating ferritin, CRP, whatever you want, interleukin 6-1, probably it's time to move from the selective activity to unselective blood purification. This is the theory and the rationale behind the sequential extracorporeal blood purification that is proposed by many experts. Difficult to apply in the clinical life, but the rationale behind is very strong. I want to conclude with the same fil rouge from the morning, that is how to move from general population to the single patient. I think that for blood purification and for many other, we are now in this way here, not there, but probably we are more close to the general population than the stratified population. But in the next future, I hope that we have more data for at least to move in the stratified population. Thanks so much.
Thank you, Massimo. Excellent. We are on time in this session. Despite we have some running behind the schedule from the rest of the day. So we are moving to the next one. So it's my pleasure to introduce you Sara de la Mata. She's a pediatric intensivist from Hospital Gregorio Marañón in Madrid. And she's going to tell us about which are the application of blood purification in the pediatric ICUs, why and when consider polymyxin-B HemoAdsorption.
Hi, good afternoon. I'm very happy to be here. Thank you for inviting me to speak today here. And to break the ice, I would like to ask you a question. You can answer me by raising your hands. How many of you have treated a pediatric septic patient? Okay, that's a few of you. You'll see that there are not many differences when treated adult patients, but we have less evidence in everything that we do. So how can I move the... Sorry.
So this one is forward,
Okay.
and this one is delayed.
Okay. Okay, so we've been talking about this. We've been talking about polymyxin filters. Polymyxin is the main filter that we have. It is made for extracorporeal hemoperfusion, and it removes endotoxin in blood. The systemic use of polymyxin-B is now restricted due to nephrotoxicity and neurotoxicity, and however, polymyxin selective removes circulating endotoxin. So this is a cut of the cartridge. You can see a schematic image of how polymyxin is added to polystyrene derivative fibers. So this is a comparison chart between the polymyxin cartridge for adults, which is the 20R cartridge, and the smaller one, which is pediatric cartridge, 5R cartridge. Its main difference is, of course, the size, and also its lower priming volume, which is very important when we treat patients that are smaller. It only has 40 milliliters of priming volume, which is very important for us. What do we know about polymyxin use in pediatrics? Well, I'll tell you that there is not much evidence. So in 2005, this first case report was published. This Japanese group reported successful treatment with polymyxin-B cartridge in a 13-month-old that weighed 8 kilograms and survived a Pseudomonas aeruginosa sepsis successfully. Then we found another case report published in 2013, also with a successful treatment of a 3-year-old boy that suffered Enterobacter coraceae sepsis. This is another case report of the treatment with polymyxin cartridge of a non-endotoxic Escherichia coli sepsis. And then in 2020, we find this report by also Japanese people. They used the neonatal polymyxin cartridge, which is only available in Japan and has the lowest priming volume, which is 8 milliliters. They compared its use in preterm neonates that were less of 36 weeks of gestational age. And they compared early onset sepsis use in 6 patients and its use in 5 patients that suffered late onset sepsis. This late onset sepsis is the sepsis that develops after 48 to 72 hours of birth. And they saw in the early onset sepsis group that they had a lower mortality rate. They had an increase in hemodynamic values, and they also saw a decrease in interleukin-6 levels. There we have another report in 15 children that suffered sepsis after cardiac surgery. They performed 2 hemoperfusion sessions using the pediatric cartridge, the 5R cartridge, and they also saw improvements in hemodynamics, oxygenation index, and laboratory signs of sepsis. The survival rate at 28 days was an 80%. And this is the last case series I'm showing you. These these people are from Thailand, I think. They report the use of polymyxin hemoperfusion in 6 children. In this case, they used the biggest column, the adult column, but they also saw a decrease in severity score, lactate and vasoactive index, and also they saw a survival rate of 83%. Well, in pediatrics, we can also use another alternative therapies that we've been talking about before. Therapeutical plasma exchange is a possibility. We have 2 different cartridges that we can use on whether the the patient's weight is higher or lower than 20 kilograms. We can also use CytoSorb, but its main disadvantage in pediatrics is its big priming volume, which is 120 milliliters. This is very big when treating small patients. So we can only recommend its use in patients that weigh more than 20 kilograms. And in patients that weigh less than 20 kilograms, we only recommend its use inserted in an ECMO circuit. And then we have auxiliary therapy. The problem with these columns is that they also have a very big priming volume, so it is recommended to use them in patients that weigh more than 30 kilograms. It is important here in order to correctly indicate the treatment, as we have been talking before, to correctly measure the endotoxin activity. So we have some ways of measuring it. We have the EAA, endotoxin activity assay, which allows us to measure endotoxin activity at the bedside. In 30 minutes, it gives a semi-quantitative measurement in whole blood. We have other laboratory tests that they need more complex sample processing, sometimes stereo. And then I'm going to speak about our small clinical experience with polymyxin cartridges. A few months ago, we used a polymyxin cartridge, the small one, in a 5-year-old patient that suffered Pseudomonas bacteremia. We performed 2 consecutive sessions that lasted 8 hours in two consecutive days. And the patient luckily survived septic shock, and we saw a reduction of endotoxin levels. Moreover, we're currently performing an experimental study in order to compare the efficacy in sepsis of different blood purification techniques. This is an experiment in endotoxic piglets, and we are dividing these endotoxic piglets in 4 groups. One group is treated with hemofiltration alone. Another group is treated with hemofiltration plus therapeutical plasma exchange. Another group is treated with hemofiltration plus polymyxin HemoPerfusion. And another group is treated with hemofiltration plus cytosorb adsorption. So luckily, we'll be talking about this in the next few years. Right now, I'm not able to give any results because this is an experiment that is currently happening. So when going back to the question that we were talking at the beginning, when and why to indicate polymyxin HemoPerfusion in the pediatric intensive care unit, we suggest to use it in pediatric patients that have a septic shock refractory to conventional treatment and with gram-negative bacteria suspicion. We can indicate it if we have the endotoxin measurement, and this is higher than 0.6 units per liter, or we have a high microbiological suspicion of gram-negative involvement. It is important to start this as soon as possible in the first 6 hours of patient care. We'll perform 2 sessions of hemoperfusions, 18 to 20 hours apart, and it can be performed with simultaneous continuous renal replacement techniques if the patient has acute kidney injury. Well, a few words about the future. We are seeing a change in the profile of septic children as we have more cancer survivors and immunosuppressed children, and this leads to an increase in gram-negative sepsis. So we'll be using polymyxin HemoPerfusion many times. Again, measuring bedside endotoxin levels is crucial, and of course, we need more clinical studies in children. Thank you, and I'll be happy to answer your questions.
Thank you. So it's time to open the session for the debate. Any question? So according the different algorithms and protocols, if we don't have endotoxin activity at that site, because we are, centers that have a specific interest in that and we have it available. But for those that don't have this determination available, which is your recommendation, how we should select patients without endotoxin activity?
In children before.
Well, in children, it depends on your laboratory, of course. If you have these molecular techniques that identify early your pathogens, it is easier. If you have Escherichia coli or Klebsiella or another gram-negative pathogen, it's, I would indicate it. There is a problem when you don't have these techniques. Maybe if you have a gram-negative bacteria in the gram testing and your microbiologist is able to warn you, or maybe if you have the suspicion of a urinary tract infection, of an abdominal sepsis, maybe in those cases I would indicate it if I don't have the endotoxin activity.
Yeah, the same approach now in the center. When we have the endotoxin activity, first of all, we use hemoperfusion very rare, maybe 3-5 patients per year with endotoxin measurement. And if you have not, probably you have to stay only in patients with gram-negative suspicion or demonstrated infection. Otherwise, it's too risky because we don't know exactly what we are doing, what we will remove from the blood and from the interstitial space. So I suggest to stay only in gram-negative infection, abdominal, pneumonia, or other infection like that. Yeah, there's a question from Massimo.
Just a practical question. Supposing the endotoxic shock and the patient in severe and refractory septic shock, what is the practical suggestion if one want to use the Polymyxin-B filter? When to start? For how long? And how much?
Okay,
we do have a philosophy, but I would like just to know yours.
Yeah. Of course, you are mentioning refractory septic shock, and this is, and Massimo alluded to that. This is a difficult definition because we don't have a standard definition. But let's say that the patient is with optimal hemodynamic monitoring and optimal hemodynamic management with multimodal vasopressor support, and also is with the right antibiotic, and we have escalated antibiotic because the patient is not doing well, and we are very convinced that the source of infection is controlled. But despite that, the patient is still increasing the dose of vasopressors, and we are not able to prevent that the patient progress in organ damage and in organ failure. In that situation, we start as soon as possible. In our case, we are measuring levels, and we are selecting patients based in levels. We are measuring cytokines, endotoxin activity, immunoglobulins, so a big panel. But if we are in this situation, endotoxin activity is above 0.6, we treat those patients.
We have changed our philosophy because we treat only those patients whose range is in between 0.6 and 0.9.
Yeah.
Because you never know what you do with the higher levels.
The alternative is to increase the dose, so to treat patients for a long time or with 3 filters, etc. This is an alternative, but this is just an hypothesis and this is undemonstrated.
Yeah, like tossing the coin.
Yeah.
Yeah, but just a comment on that. Two comments, sorry. First of all, Massimo, if you have the endotoxin activity, the measurement of endotoxin activity, the risk is only to spend more money, but there are no harmful effects in the Euphrates trial. So I would say that, of course, if you have a patient with gram-negative and very refractory shock, not too late, not too early, but as Richard said before, probably may have sense to start independently of endotoxin activity measurement, because you haven't. Because if, for example, in some blood purification, you have some harmful effect by using, in this case, all the data are in some way in the safe part of the story, no harmful effect, only money. The second point that I want to stress you is that sometimes, I know that this is not a correct approach, but sometimes the endotoxin removal is a bridge for surgical control of a source. So if you haven't a source control and the patient could have a second look of abdominal surgery the day after, probably to maintain the patient in good condition, removing endotoxin from the patient could be a way for just supporting a bridge for the day after.
Provided the fact that they will put on the control with
Yeah, definitely, agree, definitely. Have you any?
No, I agree with what you said.
You mentioned...
Thomas there.
Okay, Thomas, go ahead.
Okay, so how do you decide if you start a second session? You start one session of Polymyxin-B HemoPerfusion, and then you said in your protocols you have a second session. Is it all the time a second session, or sometimes you stop, or how do you decide?
Well, our experience is just one patient. We follow the guidelines of Torimixin. The decrease on endotoxin levels supported what we did. We saw a decrease on endotoxin levels, but they didn't return to baseline on the first day. So we decided to perform a second session, and we saw the patient's improvement. It improved after the first session, and it also improved after the second session. I mean, it was a multimodal treatment. She was also on antibiotics, on vasopressors. It's difficult to say which of these improvement was only because of hemoperfusion, but I mean, we have a one-patient experience, so that's what we can say. I don't know if Massimo can say more.
The standard dose is 2 hours, 2 days. This is the standard dose, but again, we personalize. So if the patient, second day, there is an improvement in SOFA score, and it's an important decrease in endotoxin activity, why to treat this patient for a second time? So we are individualizing patient to patient. I have a question for you, Sara. It's regarding therapeutic plasma exchange. So in adults, really, I think maybe Thomas or somebody else in the room have some experience, but there is this exchange trial, and then there is a second exchange trial coming. So maybe in the future we have some evidence that this may work. But at least for me, I'm a little bit scared of using such a resource of plasma for that, and compared to absorption. But I understand that replacing is not only removing, it's removing and replacing. So it makes sense that maybe it may work. But still, I'm a little bit scared about using plasma for septic patients, which is the amount of patients that we may treat if these trials are positive. So maybe in the pediatric field, you have more experience with that, and which are your experience with that?
Personally, in our unit, we have treated many patients with therapeutic and plasma exchange. Our guidelines, our international guidelines, recommended for TAMOF, which is thrombopenic multi-organ failure, and that's a clear indication. Well, I would say that we have very low resources for management of septic patients, as we don't have in the hemoperfusion department, we don't have many filters or many options. And I would say that it works. I didn't bring the papers because this was just a hemoperfusion talk, but we are using it and we are happy with the results.
Okay. Let's see, I think we can close.
Okay, thanks so much. Thanks to the speaker, and thanks to you to be here, and move to the next session. Thanks so much.